I'm going to talk. So I'm going to talk for about 5 minutes or so, and if people come in during that period, trust me, they won't miss much, and then we'll move on to dose. So my name is Josh Sames. I'm the director of the Center for Brain Science and will be for another 5 days. And after that, I will continue as a neuroscientist and a professor of molecular and cellular biology. So I want to welcome everybody to Bipolar 101, which is going to be run by Dost Ongur, whose face you can see. We have close to 100 people signed up. I think we'll see how many come in. It's in the mid-70s already. And based on self-reporting, the attendees seem to fall into 3 groups in roughly similar proportions. About a third are actively involved in bipolar research. Another third, or just under a third, are in labs that aren't currently doing bipolar research but would be interested in getting started. And another third are just generally curious about bipolar disorder. And I think Dost will have something to say to all 3 of those groups. The event is sponsored by the Dampened grant program that has been funding basic research at HBI, I think for 5 years now. This program funds research that can help us with understanding and eventually treating bipolar disorder, but it funds basic research, disease-relevant basic research. And we interact ever more closely with a more translational and clinical initiative at MGH, which is run by Andy Nierenberg and is called the Dampened Center for Bipolar Treatment Innovation. We're grateful to the Dampened family, Kent and Liz Dampened, and more recently their daughter, Jenna Tone, who have funded this effort. And they've just recently been joined by Petrie Daring in this, which is now the 5th year of the program. For the 5th year, we just announced a set of 9 awards, 8 individual awards, and for the first time, a collaborative award with increased funding because it's going to fund an effort between 2 labs. And over the years, we've made a total of almost 50 grants, totaling almost $5 million. And on the website, I don't have time to go into what's been discovered, but many things that are relevant to bipolar disorder and many initial results that then served as a springboard for longer term funding from NIH and other places. Let me introduce Dost now. Dost got his MD and PhD at Washington University. A few of you may know that I spent 25 happy years at Washington University. I view it as the origin of most good things in the world of neuroscience, Dost being one of them. He did his thesis there with a really terrific neuroanatomist named Joel Price. And for his thesis, he did some work on connectivity among regions of the forebrain, primarily in non-human primates. But for a big part of it, he actually did groundbreaking work using postmortem brain samples in which he was counting neurons and glia and showed a surprising, at the time, reduction in glial cells in some regions of the brain, prefrontal cortex, I think particularly in mood disorders. And this really started a cottage industry. People have followed this up. I'm happy to say it was a reproducible finding. And Dost's initial paper has now been cited well over 1,000 times. So with that as a springboard, he did his psychiatry training at McLean's and then joined the faculty there almost 15 years ago, where he's now a professor of psychiatry. And in his work there, he continues to see patients, but he also does research. Some of it follows directly on his early work on glia, but he's increasingly used a variety of non-invasive methods to probe deeper into defects in bipolar disorder and other behavioral disorders, documenting abnormalities in connectivity physiology, and even a few cases, molecular disorders or molecular signs or biomarkers. So the upshot is he's beautifully poised to tell us about bipolar disorder, and especially relevant for bipolar 101, to relate the basic science that most of us are more knowledgeable about to the clinical concerns that we are probably most of us quite ignorant of. So before Dost starts, here are the ground rules. He's going to talk for 30 minutes or so, and that will leave another 45 minutes or so for questions and answers. Please hold the questions till after the talk. And at that point, he will answer some that he's gotten already, and then just open up for more questions. Probably the simplest is to put more questions in the chat box, and then Parazad will read them out at the end. But you can also use the raise your hand feature on Zoom if you want to do that. And again, Parazad or I will call on you. The talk is being recorded because the Doughton family was unable to attend this time. They'd been able to attend before we had to reschedule. And please understand that the questions will also be recorded. Since they're being read out, I don't think that should be a problem. And last, for all of you who are now semi-pro in the Zoom world, please make sure to keep your audios off so we don't hear things that we shouldn't be hearing. And so with that, it's a real pleasure to introduce Dost, and take it away.
Thank you so much, Josh, for that introduction, and also for the invitation to you, and also my thanks to the Doughton family whose support is making these activities possible. So I'm really delighted to be here. I hope everybody can see this. My slides, yep. So when I first got the invitation to do something like Bipolar 101, I really was excited because I thought, what a great opportunity to communicate as much as possible from a clinical research world to others, you know, who are interested in bipolar disorder and are really approaching the problem from multiple angles. But of course, the more I thought about it, the more I realized it's also a huge task to try and distill so much information into a relatively brief talk. So I'm going to do the best that I can, but also what I'll say is that probably every phrase that I use, you know, let alone sentence, could be unpacked and could become a deeper discussion. So hopefully what this will do is do a tour of the horizons for things that I think are important in relation to bipolar disorder. And then, you know, as other specific questions come in, we can certainly discuss as much as is needed. So I have no conflicts of interest or disclosures to make. And the way I thought I would approach this, for many of you in the audience who haven't seen a patient with bipolar disorder or haven't spent any time thinking about the clinical problem, of course, you know, you all are interested in it because we all appreciate this is an important issue in psychiatry and then in neuroscience. But the clinical features are good to appreciate. So I'm going to spend a few minutes talking about what exactly bipolar disorder looks like, to give you a mental image of, you know, what the important issues are. Then I'm going to very briefly touch on what treatment looks like when somebody comes in with a diagnosis of bipolar disorder. And then I'm going to talk, of course, more about translational research, what themes have emerged in bipolar disorder research that we should be pursuing, and then leave you with a couple of thoughts on the implications. So starting with clinical features, it's actually a very simple fact how you diagnose bipolar disorder. A single manic episode is sufficient to diagnose bipolar disorder. And I'm going to go into what a manic episode is in a minute. But the reason clinicians oftentimes, you know, appreciate working with people with bipolar disorder, it's because a manic episode is really a signal event. It's actually high amplitude. You can't hide it if you have it. You can't fake it. It's not easy to appear manic if you're really not. And also for clinicians, you can't miss it. So it's sort of a friendly clinical presentation. And probably many of you know, there are a lot of debates in psychiatry about diagnosis what are true disease entities, and how we should be carving nature at its joints, as the saying goes from Stephen Jay Gould originally. But in terms of bipolar disorder and a manic episode, we're actually on firmer ground than a lot of the rest of psychiatry. And in fact, one of my own mentors and a senior clinician and researcher at McLean, Ross Baldessarini, wrote in the introductory editorial for the journal Bipolar Disorders that bipolar disorder is as close to a disease entity as we have in psychiatry. So it's actually a friendly introduction, thinking that there is decent agreement among clinicians on what constitutes bipolar disorder, at least when it comes to the core phenotype. And I'll qualify that in a minute. So what is a manic episode? This is actually the DSM criteria. You probably have all heard about the Diagnostic and Statistical Manual for Mental Disorders. It's published by the American Psychiatric Association. And people call it the Bible of psychiatry, but it's really not. It's more of a dictionary because there is no special knowledge in it. It's sort of an agreed upon set of definitions. Here's how the DSM defined a manic episode. That to be manic, you have to have elevated, expansive, or irritable mood. You have to have abnormal and increased activity and energy, or activity or energy. And then you have to have 3 out of these 7, or 4 if the mood is irritable, because irritable mood is less specific to mania. If somebody is truly euphoric, happy, expansive, over the moon, then it's easier to diagnose mania. If somebody is irritable, then you need a little more evidence. And so I'm not going to go into detail about each of these criteria. You can read them for yourselves, but so bipolar manic people have inflated self-esteem, they're grandiose, decreased need for sleep. This is not the same thing as insomnia. It's not an inability to sleep. It's simply people, when they're manic, they don't feel like they need to sleep. They're energized and rested in the morning after a very short sleep overnight. More talkative than usual, flight of ideas, thoughts are racing, distractibility, increasing goal-directed activity, and impulsivity, or excessive involvement in activities that have a high potential for painful consequences. So just to give you a mental image of a few patients that I've seen over the years, what mania looks like. Somebody who worked for the airlines and decided in the middle of the night that the website of this massive multinational airline was not up to their liking, and they tried to teach themselves enough website design and coding to try and break into the airline's website and redesign it. That's the kind of goal-directed activity we're talking about here. This is not, liking a book so not wanting to put it down. This is actually feeling things with such intensity that, most other things recede into the background. Clinicians also often talk about an increased vital sense. Manic people feel like they understand things more deeply and they see life differently from, the rest of us walking around, not manic, and not having that kind of deep insight. So mania is so important to bipolar disorder, but actually depression is the problem. Major depressive episodes are common, although they're not necessary for a diagnosis. One episode of mania is enough. But actually, in reality, vast majority of people with bipolar disorder have depression as well as mania. In fact, it's common for people to first be depressed before they have a manic episode. So as bipolar disorder is manifesting itself, mania may come later. The majority of days ill and the morbidity that people experience with bipolar disorder mostly arise from depression, not from mania. There's such a thing as mixed features. This is very commonly observed clinically, and in clinical parlance, people talk a lot about patients being in mixed states or having mixed features. This technically refers to a patient having both manic and depressive symptoms. It, of course, would happen mostly with irritability. If you can't really be happy and sad at the same time in a clinical sense in this way, but at least in terms of an irritable patient who's sleeping poorly, has lots of goal-directed activities, impulsive and grandiose, but also miserable and feeling down. Their mood experience is down, and some of the other symptoms of depression. That's sort of what creates a mixed picture. It's actually quite common. So the message here is that the easily identifiable feature that tells us what bipolar disorder is, that's the manic episode. The manic episode marks people as having this diagnosis, according to the DSM, but actually the picture is much more complex, and the experience of somebody with bipolar disorder includes a lot of depression, oftentimes, not everybody, but oftentimes includes mixed features along with that manic episode that gave them the diagnosis. Lots of other things happen in bipolar disorder. One is psychosis. So psychosis refers to a breakdown in reality testing. This can take the form of breakdown in reality testing in perceptions in the form of hallucinations. That's things like hearing voices or seeing visions when there are no voices or visions in the environment. It can also take the form of breakdown in reality testing in thoughts and thinking. So people who become fearful for their safety or feel that there are conspiracies out there against them, even though there's no evidence for them, and so on. These are typically common features in psychotic disorders such as schizophrenia. And bipolar disorder is related to schizophrenia, but of course not identical. But psychosis is common in bipolar patients, even the ones, even if they don't have schizophrenia, they have bipolar disorder, they still can have psychotic features, and as many as half, maybe more, will actually have those. Then there's something called Bipolar Two Disorder, which is a little different. I already used the term the core phenotype for bipolar disorder. By that we mean these, patients that have very clear-cut manic episodes, and then the diagnosis is not in dispute. That's typically called Bipolar 1 disorder in the DSM. Bipolar 2 actually requires a diagnosis of depression, as well as hypomanic episodes. And technically, according to the DSM, hypomania is like mania, but it's shorter, and it's less severe. There's no psychosis, and the person is not hospitalized for it. People can have some of the same experiences. So bipolar 2 disorder is typically considered somewhat less severe, more depressive than manic compared to bipolar 1. And there's been a lot of debate about how to define the boundaries of bipolar disorder, because as you go from these core phenotype patients to kind of concentric circles of people who are less and less severely affected, you end up blending into the general experience of people who are moody, who are sometimes not functioning well because they don't feel great, but nobody would say that they have a frank bipolar disorder. So it looks like the bipolar diagnosis is easy to make at its core, but then there's actually gray areas where there's sort of continuation from everyday average experience into the experience that becomes pathological. So bipolar disorder is one of those, bipolar 2 disorder is one of those concentric circles. If you include all of the subtypes, bipolar disorder is not rare. In fact, most epidemiology indicates bipolar 1, bipolar 2, and some of the others, less commonly diagnosed subtypes that I'm not going to go into. Over 2% of the population can be diagnosed with a bipolar disorder. This is actually more common than schizophrenia, but it's also more common than ALS, Lou Gehrig's disease, more common than cystic fibrosis, more common than multiple sclerosis. Many of these conditions that are, of course, well known in society, and a lot of research goes into them, are nothing compared to bipolar disorder. The incidence in men and women is about the same, which is different from depression, where women get a lot more major depressive episodes than men do. But if you look at people with bipolar, it's actually about the same. The sex ratio is 1. And bipolar is a big deal. It's so common. And of course, it's can be associated with a lot of morbidity, meaning time lost at work, inability to live on their own, loss of quality of life, and dissatisfaction with life. You put that all together, the cost to patients and families, of course, is incalculable. But also, there's an economic burden to society. Just all of the direct treatment cost is only about $7 billion a year. Of course, I say only tongue-in-cheek, but actually the economic burden, when you take disability payments and Medicare, Medicaid expenditures and other things into account, the indirect costs, the economic costs, and the time lost from work and contributing to society, you're talking about tens of billions of dollars that society spends every year in the United States alone to combat bipolar disorder. And the cost per patient a year is more than $20,000 a year. So this is actually a big deal in lots of different ways. Clinical lore historically had it that bipolar disorder was a good outcome condition. So you might have heard or read things about classic composers, painters, political leaders having bipolar disorder. And there's been, lots of work on what people would sometimes call psychological autopsies, looking at how people's lives evolved and diagnosing them retrospectively. you know, based on what's known about historical characters. This is always a treacherous thing, but that's been a cottage industry in bipolar disorder. And the idea comes something like this. Look, if you're an outgoing, talkative, hyper, positive, charismatic person, you're going to be more likely to be a leader among people, leader in society. And, you know, those traits are largely adaptive traits in social life. But of course, if that then is emphasized and extrapolated to a pathological degree, then you pay the price with having a bipolar disorder. So this relationship between, you know, high functioning, unusual people and bipolar disorder has been clinical lore. Not a ton of rigorous research actually into this, a little bit. And of course, the picture that I have here, some of you may recognize, is Kay Redfield Jamison. She is a clinical psychologist who is a professor at Hopkins, at Johns Hopkins Medical School. And she herself has bipolar disorder and has been very public about her own experience and her own journey. She wrote An Unquiet Mind, which is a fantastic read. If you're interested in understanding the experience of bipolar disorder better, you should look into it. But she also wrote another book called Touched with Fire, which is actually about creativity and bipolar disorder. So she explores this topic. But of course, the reality is, this is not something you would choose to have. Long-term functioning is worse than previously appreciated. There's a lot of morbidity, difficulty staying in school or holding down a job, difficulty in relationships, difficulty living independently, and so on. So this is not, you know, we shouldn't romanticize the idea of creativity and leadership in bipolar disorder. Of course, many people do very well. Kay Redfield Jamison is an example of somebody who, you know, has managed her illness so well that she's performing at the highest levels, you know, well above average compared to her peers, for example. So it's also not a barrier to doing well, but it is something that people with bipolar need to grapple with. What are some clinical things that we struggle with taking care of people with bipolar disorder? Big one is medication non-adherence. Especially when people are manic, and it's also especially if psychosis is thrown in there, many people have what's called poor insight into their condition. The term for this in neurology is anosognosia. You might have heard about this. Certain kinds of strokes, for example, make people unable to appreciate that they have a problem, that they've had a stroke and they can't move their right arm, for example. Something similar can happen with bipolar disorder and other psychiatric conditions, especially schizophrenia, where people who have not been able to hold down a job, they're not able to live independently, will say, I don't have a problem, everything's fine with me. You know, everybody's worried about me, but I'm fine. And of course, a corollary to this is that a lot of people with poor insight also then have a poor relationship with the treatments that are being offered. If you don't think you have a problem, why would you go see the doctor? Why would you take medication that's being offered? Why would you go into therapy if you don't think you have an issue that needs therapy? So non-adherence with treatment, and especially medications, is a chronic issue. Substance use. Interestingly, it's not self-evident why this should be, but we'll get back to it. A huge percentage of people with bipolar disorder also have a diagnosable substance use disorder. This can be alcoholism, this can be cannabis use disorder, but it can also be cocaine and stimulants. It can be heroin or other opiates. It runs the gamut. Of course, substance use disorders are common in people with psychiatric disorders. So depressed people also have a higher likelihood of having a problem with alcohol, anxiety disorders, and plenty of other things. But among all of the psychiatric conditions, bipolar disorder in most studies stands out as having the highest, what's called comorbidity. They're both happening together. This is telling us something. We don't, you know, there's something about reward responsiveness. It hasn't been worked out perfectly, but the notion that there's such a strong relationship between bipolar disorder and substance use disorder is well established. Suicide is another big challenge, and you know, huge numbers, depending on the study you look at, but 5%, maybe even higher, of all people with bipolar disorder die by suicide. This is a huge clinical challenge, and clinicians working with people with bipolar disorder are always on their toes about reducing the risk of suicide because it's just so common. In some of the other major psychiatric disorders, you know, you see these kinds of numbers as well. And in case, you know, this isn't something you've looked into, 5% of all bipolar patients is such a huge number. For example, you know, in most countries, in most Western countries, the number of suicides runs something like 1 per 15,000 or 10,000 person years. So, you know, it's much, much lower than 5%. And in fact, a quarter of all patients will attempt suicide at least once in their lifetime. So this is a clinical challenge that people have to be worrying about. Okay, just a few words about treatment. We use medications as a mainstay of treatment for bipolar disorder, and especially mood stabilizing medications. This term refers to treatments that will reduce the likelihood of having a manic episode or manic symptoms, and also reduce the likelihood of having depressive episodes or depressive symptoms. One of the leaders in this category is lithium. Both the lithium salts like lithium carbonate, but also the lithium acids like lithium citrate are mood stabilizing. This was discovered serendipitously in the 1940s, and to this day, we don't have a very good explanation for why a rock salt like lithium, essentially similar to sodium, should have this property when sodium itself doesn't, of course, and many other elements don't. So it's an interesting challenge. But certain anticonvulsants are also mood stabilizing. Valproic acid, carbamazepine, oxcarbazepine, lamotrigine were all initially used in neurology as treatment for seizure disorders. But clinicians who noticed similarities between people with seizure disorders and people with mood disorders like bipolar disorder thought maybe that some of the same treatments may be useful in psychiatry as well. And sure enough, some of these medications have excellent efficacy in treating bipolar symptoms, but not all anticonvulsants. So the idea seems to be that this is not just about having anticonvulsant properties. There's something that's shared for the ones that do have mood stabilizing properties, but one of the commonly used ones, phenytoin or dilantin, is not a mood stabilizing drug, even though it's an excellent anticonvulsant. Barbiturates, gabapentin, levetiracetam, this is Keppra, not particularly good mood stabilizers. Antipsychotic medications that are primarily used to treat schizophrenia, but actually can also be useful in bipolar disorder. So even though the term is antipsychotic, they also have anti-manic properties and even some antidepressant properties. Their properties vary depending on which specific medication you're talking about. I'm not going to go into that, but just to highlight that it's not only lithium. There's a whole armamentarium of various medications that can be useful in bipolar disorder. And among the antipsychotics, the one that stands out is clozapine. Clozapine has particularly good mood stabilizing properties. Clozapine is not an easy medication to use. Some of you may be familiar with it. It's also used in schizophrenia, but it's associated with significant side effects. So it's not first-line treatment, but for extremely treatment-resistant patients, even with bipolar disorder, we'll consider clozapine. Antidepressants may have some role. This is hotly debated. It's clear that antidepressants are useful in major depressive disorder, of course. In bipolar depression, they are not as useful. There's no doubt about that. And their downsides are much greater in bipolar patients than they are in unipolar depressed patients. And yet, some studies indicate that for people who are severely depressed who have responded to antidepressants in the past, it may still be worth trying them. So clinicians differ on this, experts differ on this, but it's in the picture. But the issue is that antidepressants should not be used as monotherapy. The patient should be on a mood stabilizing medication before you use antidepressants. Psychotherapies, of course, most bipolar patients will be in some kind of therapy. Cognitive behavioral therapies are used, a variety of interpersonal therapies. Therapy in bipolar disorder tends to be long-term. This is not a 12-session therapy that's going to help somebody get on their way. You're really managing a chronic, relapsing, remitting condition. So you really have to support that person through the ups and the downs. And so most therapists use supportive problem-solving approaches that are primarily used to enhance stability and medication adherence. So you're kind of managing a long-term illness and providing the person that support. And because, again, these are chronic, relapsing, remitting conditions, family-focused interventions can be useful because in many cases, the individual patient's family are really the first-line stakeholders, and they have a huge role to play in supporting that individual and reducing harm. For example, supporting that person to not engage in substance use and supporting them if the person is actually at risk for suicide and so on. And so there's some family-focused interventions clinicians also use. And then the treatment strategies, mood stabilizer in every phase of illness. That's sort of the bedrock for treatment. But then there's lots of other things that will happen depending on the phase of illness. If somebody is depressed, for example, you might try to treat that depression with a variety of medications. Sorry about that. Medication changes are going to be common. There's other medicines that come into this. If you're interested in benzodiazepines, which are anxiety drugs, these are things like Valium, Clonopin, Ativan, Xanax, you might have heard about, or sleep aids like Zolpidem or Ambien are used. So depending on the phase of illness, clinicians are often juggling a lot of different medications. The term for this is polypharmacy. So bipolar patients actually are prescribed lots of different medications, and they stand out among all psychiatric patients. In most clinics, it's the bipolar patient who's receiving the largest number of medicine. That doesn't mean they're on the highest doses or the medication burden is high. It's just that we use a lot of different medicines to actually treat the various different manifestations of bipolar disorder. Okay, now so I'm going to spend a few minutes talking about the translational aspects. What are we learning from bipolar disorder clinically that then can be used to advance the research agenda that hopefully will lead to advances that can then be used to improve the lives of our patients and their families. So several themes have emerged. I'm going to talk briefly about what I call instability variability, and I'll explain what I mean by that. Then I'm going to say a few words about reward processing abnormalities, circadian rhythms and sleep. And then I'm going to add a couple of things about genetics, animal models, and sort of therapeutics research. You know, what do we learn from the treatments for bipolar disorder? So instability and variability. If you step away from everything that I just said for a minute and think about what is the challenge here, how do you think about a physiology for something like this? Well, bipolar disorder is episodic. So the symptoms are not continuous once you start having them. Certain but not all abnormalities are found when people are euthymic. That's a term for when they're neither depressed nor manic, so the mood is more or less normal. But euthymia is a compensated state. It's not a truly normal state. It's not the absence of the disease. People with bipolar, even after prolonged periods of euthymia, retain their vulnerability. They might have future episodes. And then how do episodes start? They can start with environmental events or endogenously. Sometimes you can't identify a very clear inciting stimulus. But sometimes you do. Sometimes it's severe sleep deprivation, for example, that can trigger manic episodes, or substances of abuse. If somebody goes on a cocaine bender, you know, for a long weekend, they might actually spin off into an episode, either a manic or a depressive episode. So that's one thing. There's this variability in the presentation. That's episodic, but also the episodes are different, right? You have manic episodes and depressive episodes. So the same individual can appear very different, separated by only 3 months in some cases, for example, or of course longer. It almost makes you question, how can this be that the same brain, the same individual can cycle through such different states? And yet, of course, it's not enough to explain mania for bipolar disorder. We also have to explain why almost all bipolar patients also get depressed. So you need a physiology that actually explains both presentations, which is difficult. You know, once you trigger these environmental events or endogenous episodes, it's relatively stereotyped. We recognize a manic episode when we see it. So all manic episodes share certain features. So why is it that you can push lots of different people into this condition, into this episode, but once the brain is there, it actually sort of settles into a relatively stereotyped behavior? And then another fascinating reality in bipolar disorder is that these episodes are self-limiting. There's lots of descriptions from the pre-modern era, going back into the ancient Indian, Chinese, and Western Greek and Roman texts of descriptions of mania and melancholia that were self-limiting and sort of burned themselves out. So once the brain is in that condition, there must be some compensatory responses that actually start to cycle the brain back into a more normal situation. So we have to explain all of this with a single physiology, a single disease that does this. Starting in the 70s and 80s, clinicians started to say, you know, it's not enough to treat a patient when they have a problem. We have to understand the life course of this illness. And maybe that'll give us clues about this instability. Do we see any patterns on when people get manic, when they get depressed, and so on? So they started developing what are called these life charts for tracking manic symptoms and how severe they get over what time period on the x-axis here, or depressive symptoms going below the 0 line, and then adding when alcohol and substances were in the picture and other life events and so on and so forth, so that you could actually sort of put this all together for potentially many years or a decade or two of somebody's life and look at it and see if you can see patterns. There was a lot of research along these lines. Unfortunately, it didn't really quite lead to the hoped for result. The idea was that maybe we're going to identify patterns. For example, people become manic once every 10 years, and they become depressed twice every 10 years. I'm just making stuff up, but that's the kind of pattern that you might have been able to recognize if you did this in enough numbers of patients, or maybe you would discover subtypes. And of course, the bipolar 1, bipolar 2 subtype distinction is very valid, but the life chart approach, really what it ended up doing is it captured the heterogeneity and the instability in bipolar patients. There's something nonlinear and sort of chaotic about when episodes come and how they cluster, or why people become stable for long periods of time, that we don't understand very well. And in fact, Andy Nierenberg, who's in the audience, has done quite a bit of work on trying to understand these patterns, using modern approaches, building on some of these charts. So this notion of instability and this sort of nonlinear dynamic picture is really something to keep in mind. That's what we've learned clinically. We also know that there's lots of biological findings that oscillate with disease state. People have done CSF levels of the monoamines and their metabolites, and you see them changing depending on whether the patient is depressed or manic. There's imaging studies showing the same in both PET and functional MRI. EEG, even vital signs and neurovegetative symptoms can go in opposite directions. So this has led to the awareness that there are state-related and trait-related findings. The state-related findings are things like this that oscillate over time. So they, of course, are changing, but we don't exactly know what that pattern is or why that's happening. Trait-related findings are things that are always there, even when the person is not symptomatic, and it should be shared in depression and mania. Those have been harder to come by. There's, of course, some research leads about that too, but we haven't been able to wrap our minds and arms around the biological oscillations and the instability. Just to drive this point home, this is a slide from a very old mid-1980s PET scan with fluorodeoxyglucose. The same individual, depressed, hypomanic, and then depressed again, scanned 3 different times, separated by only a few months. And you can see how dramatically different the glucose utilization in the brain looks. These are horizontal cuts parallel to the ground. And here's the top of the brain. This is the middle. This is the bottom. The top row here is one scan. And then you come back a few weeks later, and this is what the same scan looks like in the same individual, in the same machine. And then you come back again a few weeks later, and this is what you see. This is a good mental image to keep in your mind. So clearly, there's no lesion of glucose metabolism here. The problem is not in one direction. The problem is not a deficiency of something. The problem is instability. The problem is violent swings in an important biological measure. Okay. So if you're thinking about this inability to remain in homeostasis and disrupted stability, neuroscientific mechanisms that might come into play, intrinsic oscillations in the brain, response to perturbation, activity-dependent regulation changes that may become abnormal and impaired. Of course, plasticity mechanisms, metaplasticity, and even neurodevelopmental trajectories in bipolar disorder, where many people with bipolar disorder actually have average or above average functioning even before having the diagnosis. So scholastic achievement, for example, is, depending on the study you look at, average or above average for most people with bipolar. Whereas in schizophrenia, that's not true. There's actually a decrement in scholastic achievement pre-morbidly before the diagnosis has been made. So something in the developing brain is actually developing well and maybe even above average, but then it's spinning off this abnormality. Reward processing. The way I say this is when you're manic, everything seems fun. When you're depressed, nothing seems fun. The reward responsiveness roughly breaks down in that way. I already mentioned the high rate of substance use disorder comorbidity. There's a large literature on abnormal activation of reward processing regions in neuroimaging studies, and the laundry list of abnormalities in forebrain and cerebellar circuits too. Subservient cognitive affective processing I'm not going to go into, but includes cortical thickness, white matter integrity, activation connectivity, and neurochemical changes as well. And this is just a summary from a review article of reward responsiveness as summarized in imaging studies. And, they show elevated approach-related motivation and reward responsiveness in mania, and then anhedonia and reduction in reward responsiveness in either bipolar depression or unipolar depression. But of course, remember, mania and bipolar depression happens in the same person. That's why I put this green box around these two boxes, these two stops there, because we have to explain how the same person can sometimes have elevated and sometimes reduced reward responsiveness. Circadian rhythms is another one. Abnormal sleep and other circadian behaviors are a cardinal feature in bipolar disorder. And this is much more true for bipolar disorder than any other psychiatric disorder. There's a seasonal pattern to episodes when mania is more common in the spring and summer, and depression in the fall and winter when days are shorter, in the northern hemisphere, for example. Induction of mania with sleep deprivation and travel across time zones is a well-known feature. I already mentioned sleep deprivation. And then phototherapy, the light box treatment, some of you may have heard about, and sleep entrainment. You can actually intervene in somebody's life in ways that enhance their circadian rhythms and make them be really alert and awake during the day and more quiescent in the evening and sleeping through the night. That's actually therapeutic. So there's a relationship in both directions here. In the interest of time, I'm going to skip that slide and just briefly mention the clock mutant mice. This is the work of Eric Nestler, who's now at Mount Sinai, who actually generated a genetically modified mouse where the clock gene function was disrupted. Clock is critical for normal circadian rhythm generation. And these mutant mice are hyperactive at baseline. They respond strongly to novelty, which is not something that wild type mice do as well. And then they're hypersensitive to cocaine. So this actually recapitulates a few different features of bipolar disorder. So that's my segue into animal models. Several of you asked about this in the pre-meeting questions. There's no single established model for animal model for bipolar disorder. There are many historical examples. I mean, the classic one going back into the 70s and 80s is amphetamine-induced hyperlocomotion. You can actually repeatedly inject animals with amphetamine, and they have sort of that reaction of becoming hyperactive during the period following the injection. But after enough repeated injections, these animals become hyperactive even at baseline. So this was considered to be something of a model for mania. Others have promulgated maternal immune activation, various disruptions in GABA glutamate, cholinergic, ion channel pathways, signaling pathways involving especially mTOR, and I'm going to get back to that, and intracellular signaling cascades have been implicated. Mitochondrial dysfunction has been implicated, and this is one where we do some of our work in collaboration with senior colleague Bruce Cohen, who was president of McLean and is still active in this line of research in bipolar disorder. The clock mice I already mentioned. My message to all of you is that it's unlikely that we're going to identify a single animal model that recapitulates the disorder. This is a complex human disorder. It's multifactorial. And as we've been saying, it's highly variable in its presentation. This is not going to lend itself to some kind of animal model. And in fact, the director of NIMH, Josh Gordon, says, it's fine to have animal models for psychiatric disorders, but you're not going to get animal models of psychiatric disorders. And what he means by that is that we should be aspiring to model specific aspects of the disorder that can be dissected and understood in the animal. But that doesn't mean you have a model of bipolar disorder or of schizophrenia and so on. Genetics, bipolar is a highly heritable condition. In fact, I get a chill down my spine every time I meet a new bipolar patient and I hear their family history and that they have a first-degree relative. It's very common to meet people with bipolar who have either a parent or a sibling, occasionally a child, also be diagnosed with bipolar disorder. So this is really a highly heritable condition, much more so than schizophrenia, by the way. Autism is up there, but bipolar is up there too. It's got a polygenic architecture. I don't need to lecture you about this. Many of you know a lot more about it than I do. Overlap with schizophrenia, major depression, autism, and other conditions. GWAS explains only about a quarter of the heritability, though. The GWAS studies have led to some interesting stories, like the voltage-gated calcium channel story. Again, many of you know more about these things than I do. But they're not currently as well developed as they are in schizophrenia in terms of the molecular pathways where multiple genes are being implicated based on GWAS studies. There's definitely a role for copy number variation here, deletions or duplications in the genome as well. and then probably epigenetic heritability that we have not studied adequately yet. So translational therapeutics. People who do bipolar research have noticed the peculiar story that two of our most useful medications are a rock salt, that's lithium carbonate, and an organic acid, that's valproic acid, or Depakote is the trade name of the medication. These are quite useful in bipolar disorder, and they are nothing like one another. I mean, lithium is a cation, and then valproic acid is an organic acid. So how come they have, similar effects on these unusual patients, these sort of unstable, variable patients? And then how come so many other things are useful in bipolar disorder? Antipsychotics, antidepressants, benzodiazepines, and so on. We use a lot of psychopharmacology in bipolar disorder. So there's been a lot of research into this. And one of the leaders in this had been Husseini Manji. And some of the work that he did, and many others now, has led to the idea that these treatments, although they're so distinct from one another, they all seem to impact similar intracellular signaling cascades that promote neuronal health and survival. Things like spine remodeling, synaptic plasticity. And then actually there's now a human literature where you see increased gray matter volume and brain and acetyl aspartate content in humans. And acetyl aspartate is NAA, and it's a neuronal ingredient that it has been used as a marker of neuronal health in Alzheimer's disease. And so giving healthy people lithium actually gives you more brain tissue and higher NAA levels, and giving bipolar patients lithium does the same. So there's a lot of imaging studies now before and after lithium therapy, and this has been a replicated effect. So something is going on with these treatments for bipolar disorder and their effects on neurons. Of course, these are very non-specific findings. Similar things may be happening with other treatments. And also, why would improving neuronal, NAA content somehow be mood stabilizing? We really have no good answer for that. But this is an interesting lead that's come out of translational therapeutics. And then I throw up this figure from an old paper from 2010 in Science. Some of you may be familiar with this, the work of Ron Duman and his group, which I'm not going to go into details, but what they showed in this paper was that the antidepressant effect of ketamine, which has been a very popular antidepressant treatment recently. It's not bipolar specific, it's used for depression more broadly, actually is related to ketamine's impact on mTOR signaling. And they showed this by using rapamycin to block it. And so there is this interesting relationship to these intracellular signaling cascades and what they do for neurons that we've really gleaned just some insights from the treatments that we use. So to sum up, what I can tell you about bipolar disorder research is that the etiology is elusive. There's no doubt that there's multiple factors of variable strength, but with unpredictable interactions, and each individual's path to becoming diagnosed with bipolar disorder is different. A quote from Richard Feynman, who headed up the committee that reviewed the space shuttle disaster back in the 1980s, and the first sentence of their report was, "Complex systems break in complex ways." It's not realistic to think that we're going to discover some kind of lesion that explains bipolar disorder. What we need to understand is the meta-level processes that govern stability and brain function over time, and that's probably what's going to lead us to more insightful advances that can help our patients. Okay, so thanks for tuning in, and thanks for your attention. This is an aerial picture of McLean Hospital, which is where I work, and I've been for 20 years now. We're out in the suburbs. Parking is free. We see a lot of people with bipolar disorder and all other psychiatric disorders. So if you're interested in understanding these conditions better, by all means, feel free to get in touch with us, and we'll be happy to share what we think and what we know with all of you. Okay, I'll stop there. And I think I answered a few questions. Like, one of the big themes was animal models, and I said some things about that. But I'm happy to talk in more detail about anything that's coming up for people.
Well, that's great. That's fantastic. And do you want Arzad to read out more questions now, or how do you want to handle it? I'm sure I see lots of questions on the chat, and I'm sure there'll be more coming. Do you want to read them out, Arzad?
Yes, I'm happy to. So our first question is from Rick Bourne. How frequently do unchecked episodes of mania progress to psychosis?
So in fact, that's the usual mechanism. In bipolar disorder, psychotic features are considered a mark of severity. If the treatments aren't working, or if somebody's been untreated for a long period of time, the progression to psychosis is actually common. And in fact, for some patients, those psychotic features that are first within episodes eventually become more longer lasting, and the diagnosis is then converted from bipolar disorder to schizoaffective disorder, or sometimes even schizophrenia.
Oh, and Rick, I know you have your hand up. Did you want to ask more about that?
Oops, sure, sorry. It's actually a slightly different question, Dost. First of all, thanks. That was really enlightening and helpful. I guess I was going to ask, you know, it seems to me that all of us have variability in our moods. Some days our mood is good, some days are bad. And that one might think of this disease, as you sort of alluded to, as sort of a dysregulation of some kind of damping mechanism, or some mechanism that you said keeps our moods within the normal range and prevents them from oscillating wildly. And I guess I was just wondering what's known about sort of mood swings or changes in people who aren't diagnosed clinically with mood disorders.
Yeah, so, you know, there's more interest in that. And actually, again, Andy Nirenberg has sort of made this argument that we should be studying the stability and patterns of mood over time to understand what are the mathematical rules, right, that govern that kind of fluctuation. And then what can we learn about that damping or compensatory mechanism that may be abnormal in bipolar disorder. This has gotten a lot easier to do with modern technology. Until recently, a lot of what we had was things like that life chart I showed, where, you know, you have a piece of paper and you're trying to scribble on what you think is going on. But with digital phenotyping, you know, you can get not only pretty granular information just by asking people, let's say 3 times a day, how their moods are, but also you can see signatures of their activity and behavior through passive data collection in smartphones, like, you know, pacing or GPS, you know, physical location, and vital signs and other things. You know, there's a lot of excitement about all of that. So, you know, there's more to it than I can probably summarize for you. But what I would say to you is there's a lot of interest in this, accumulating evidence, no easy story to tell, no one sentence that says, oh, here's how that works. But I think that's exactly the question that people are looking at now.
Thank you. So we have another question. So from Madeline, are people with bipolar disorder higher on impulsivity in both mania and depressive states compared to just MDD? How does this contribute to suicidality in depressive episodes?
Yeah, that's a great question. So impulsivity is a core feature of mania, to be sure. So it's really associated much more with mania. So it's not quite as simple as, oh, bipolar people are impulsive, so when they're depressed, they're just more impulsive and they may attempt suicide more. It doesn't quite work that way. It's really mania that it's associated with. But there are features of bipolar, you know, patients that contribute to suicidality. Irritability and anxiety tends to be higher among people with bipolar disorder, even when they're not depressed or manic. So there are these sort of baseline, you know, smoldering, or what Gary Sachs, who was another one of my mentors or supervisors, has called roughening. You know, that when things were going well, things were smooth, but now there's roughening. Those are the kinds of features, those are the times when you see these features, like irritability, anxiety, that actually do elevate the risk of suicide attempts. But it's actually suicide and impulsivity. It's a very complicated story where access also comes into it. You know, many people who are acutely suicidal, but the moment passes if they don't have a gun sitting in front of them. But access to firearms, for example, is one of the biggest factors that can lead to a completed suicide. So there's a lot of factors that come into play for suicidality.
Thank you. So we also have a question from Josh Stern. Is there research into the directionality of the substance abuse correlation? Yeah,
so great question. There's some, you know, I guess I would call it classical literature that goes back 30, 40 years now, that could be summarized as when people are down, they use uppers, and when people are up, they use downers. there were some clinical evidence backing that up. So during depression, things like psychostimulants, cocaine or amphetamines may be more likely to be abused, whereas during mania, alcohol may more likely to be abused, or benzodiazepines. That's not at all a rule you can hang your hat on. Like everything else with bipolar disorder, there's great variability, both within people and between people, about what substance they use at what time. But very broadly speaking, that is, there is a literature that says that.
Great, thank you. So then another question is from Michael Link. Which one comes first? Does substance abuse increase the chances of bipolar onset or progression, or the other way around? So I think that's kind of what you just addressed. I don't know if you have any additional comments. Or
I want to make a comment about this because the literature that's most relevant to this is actually on cannabis. So taking a step back though, before going into cannabis, this is of course very difficult to establish. If somebody, typically had abused alcohol for a decade before they had a depressive episode and then a manic episode, did the alcohol contribute to the progression to bipolar disorder? That kind of causal relationship is very difficult to establish and has been hotly debated. Very broadly speaking, well, I would say maybe most clinicians would say that's not really a causal relationship. Some of this substance use is actually being driven by subclinical bipolar symptoms. People who are anxious, people who are miserable, or people who are edgy and feel energized may abuse substances to sort of mitigate that or control it. So that's, again, it's very difficult to establish causality, but that's out there. Cannabis is a little different. Cannabis use in teenage years has been associated pretty rigorously with subsequent onset of a psychotic disorder like schizophrenia. The risk is highest for schizophrenia, and then bipolar disorder. It's a little less so, but it's definitely there as well. So, of course, the definitive study would be to take a bunch of adolescents, let's say early teenagers. The risk window is the teenage years. But if you took a bunch of 14-year-olds and randomized them, and then forced half of them to smoke pot every day until they went into adulthood, and prevented the other half from smoking any pot at all, and then you see what happens to them down the road, that would be the definitive study. That's just never going to be done. All the evidence that exists indicates that 14, 15-year-olds, early teenagers who are smoking pot daily are at threefold higher risk of developing a psychotic disorder down the road than kids who are not smoking at all. And even in face-to-face interviews where clinicians sit down with these adolescents and interview them, you can't identify psychopathology. So it's not like the odd kids, the mavericks, the misfits, or some pre-psychotic kids are smoking the weed, but actually they were driven to it because of their mental content already in the first place. They appear to be healthy teenagers, but they're smoking a lot of weed, and they're at higher risk of developing schizophrenia, and also to a lesser extent bipolar disorder. And once they have that schizophrenia or bipolar disorder, then it's garden variety schizophrenia or bipolar. You can stop the weed and you have the disease. So this is not a secondary phenomenon. This is a risk factor. The weed is a risk factor. So that's a literature to be aware of, because of course in society there's been so much debate about legalization of cannabis and so on. And my attitude has been, this is not about whether it should be legal or illegal, but we all need to know that there is a very clear health consequence to cannabis in teenagers that's related to mental health, that society should be aware of, just like we're aware of the downsides of alcohol and tobacco. Those are legal, but we all know, what some of the downsides are. There should be a similar attitude. The idea that weed is totally safe is just false.
Thank you. So the next question is from Laith. How symmetric is the intensity between the manic and depressive episodes?
Great question. So I didn't have time to go into it, but let me do it now. There is a notion of polarity among bipolar patients. Meaning some bipolar patients tend to have more manias and less depressions. Other bipolar patients tend to have more depressions than manias. They are, all of them meet criteria, but the course of their lives actually can look quite different, because with mania comes more psychosis, more action, so to speak. A lot of those patients may do things that they regret later and, go bankrupt or have sexual indiscretions, and they kind of have to put their lives back together after every episode. Whereas the more depressive polarity patients tend to be, tend to have more of these debilitating depressions. So somewhat different picture. That is not by any, again, like the rule in bipolar disorder is variability and heterogeneity. So it's not like there's two kinds of patients, depressives and manics. That's not how it works, but you occasionally see this pattern. So that tells you that it's not symmetric, right? So not every patient has equal intensity. And as a corollary to that, even for bipolar 2s, for example, where the depressions are more severe, the manias are less severe. So there again, it's sort of been shifted down in terms of their mood, the sign of their mood. So there isn't a clear symmetry there.
Thanks. So next question, we have a ton of interesting questions, is from Riley. And the question is just about treatments. For treatment, do patients typically use a combination of the medications they were talking about?
Yes. So at any given time, in fact, there was a paper several years ago at McLean Hospital. If you're receiving care in one of our clinics, you have a diagnosis of bipolar disorder. Some of those folks were on 5 different medications at a given time. So these combinations of medications, clinicians are juggling all the time to control the symptoms because also things are changing over time. Now, if you ask me to defend why is that specific individual on 5 different medications, I don't know if I should do that or not. It's not, because one thing you get with more medication is more side effects. So these are not easy medications to take. I'm not saying that this is a wonderful thing or things are as they should be, but it's sort of a clinical reality that people are struggling with a lot of different symptoms, and we use different medications to control them. The more average number is about 3. 5 is sort of the outer side, edge of that. An occasional patient is on more, but many people are on multiple.
Thank you. So up next from Mark Anderman, can the oscillation between manic and depressive be dampened by less aggressive treatment and self-medication?
Yeah, so that's another one that's really tough to, answer with rigorous, clinical trial evidence. There's a few aspects to this, but part of what's packed into this question is whether the treatments somehow are palliative. They are controlling the symptoms, but they may actually make the underlying situation worse. There's actually some thought behind that, especially for antipsychotic medications that are used much more so in schizophrenia. There is actually a dopamine receptor supersensitivity phenomenon. The idea is that if you pharmacologically block, these endogenous dopamine receptors that are required for healthy brain function, but in this condition, they have now become abnormal. They're, signaling, over-signaling. Now you come in with a pharmacologic agent and block them, but the brain is actually looking for that signal. And so more dopamine receptors are synthesized, and then they're placed into the membranes. So you have a super sensitive dopamine system. And then if you don't take your medication for even 1 or 2 days, and the pharmacologic block is removed, now you actually have overstimulation. That's worse than it would have been in the endogenous situation. So that's the dopamine receptor supersensitivity idea. So there's been a lot of concern in the field over the decades about whether, we take somebody who has a psychiatric disorder, life-threatening in many cases, life-altering in almost all, and you're trying to help them, you're trying to control the symptoms, but whether you create an underlying problem that actually can be worse. So this idea about, would the oscillation be dampened by less aggressive treatment? That's sort of the background there. Unfortunately, there's a lot of debate about this. There's some in vivo human PET receptor occupancy studies that have suggested that this might be the case, but the evidence is not strong. The evidence is very strong on the other side, that if you stop your medication, you will have a relapse. It's not, again, this is speaking generally in terms of rules of thumb here, but relapse after stopping medication is very common, usually depending on the study you look at, depending on the medication, depending on the disorder. But just to keep something in mind, for example, in schizophrenia studies, over 50% of patients will relapse in the first 6 months if you stop the medication. And by a year, that number is more like 80%. And then it goes up from there. So people who've been on medication, if they stop the medication, things tend to get worse for them. And so we try to manage this long term with the lowest possible dose of medication, the lowest side effect burden, but stability in the medication regimen, meaning that you stay on the medication so you're not jumping on and off all the time, because that actually adds to the instability. So a lot of hand waving, but hopefully some interesting notions there. Clinicians, are obviously living with this along with their patients and their families. And so there's a lot of interest in the field in reducing the medication burden and maintaining stability. But we don't have easy and good ways to do that at the moment. There's a lot of need for that.
Great, thanks. So next up is a question on model organisms from Madeline Bailey. Is bipolar-like behavior seen in non-human primates?
That's a good question. I probably say, I should say I don't know. I'm trying to think about, so this is sort of the ethnography, right, of abnormal behaviors appearing in non-human animals in natural course of events. I just don't remember anything that says that, this is common in non-human primates.
Thanks. So from Charles Jennings, is there evidence that the immune system is involved in either manic or depressive episodes? Are there genetic overlaps with immune disorders?
So generally speaking, the answer is yes. There's a lot of intriguing evidence. The effect sizes are small. So I don't want anybody to walk away with the impression that, immune activation in early brain development or, other kinds of, immune abnormalities lead to mental illness. This is a very popular idea right now, and there's a lot of accumulating evidence behind it. But again, the notion that those are the causes of mental illness would be a huge overstatement. In some cases, immune dysregulation and immune activation in early brain development in utero or in early postnatal period are certainly associated with increasing the odds of developing a psychiatric disorder. In general, odds of developing schizophrenia and bipolar disorder are the two big ones. Autism is another one where there's a similar story, where there might be a neuroinflammation cascade that gets triggered by this immune dysregulation, and it impacts brain development abnormally. That's a very attractive idea, and there's evidence behind it. But again, the human literature is actually weaker than you would like. Only increasing the odds of developing these conditions by a few percent and so on. So it's not enough to really explain the whole story. And I'm not a geneticist. I try to follow the field, and there's sort of a bonanza right now after the first wave of GWASs came out for a lot of interesting phenotypes and traits. And Mendelian randomization was proposed as a way to explore sort of causal relationships between these various phenotypes. There is a bonanza of investigators, looking at any two things and seeing if there's a relationship. That's also happening with immune disorders, between psychiatric disorders and immune disorders. It's also happening with metabolic disorders like diabetes, cardiovascular disorders, and lots of things. Dyslipidemias, cholesterol abnormalities, and on and on. So there again, the human literature is not particularly strong. In other words, it's not like you put bipolar disorder up against a series of medical conditions and you say, which one of these is the thing that's associated with bipolar disorder? Any one of them actually jump out. The evidence is accumulating that all of those things are associated with some mental illness, and definitely bipolar as well. But the links are intriguing, but not particularly impressive.
So next up from Josh, are sleep and circadian features seen early in the disease course, or do they appear gradually or later?
So yes, early in the disease course, yes. So this is these sleep and circadian features are cardinal features of the illness. There's something about how the brain is keeping track of the passage of time and the rhythms of day and night and rhythms of life that is disrupted in bipolar patients. One thing I mentioned is the lack of need for sleep. Even there, the typical bipolar patient, even when they're well, will actually have a non-rhythmic sleep system. So they'll sleep, 5 hours one night, 6 hours the next night, 13 hours the third night, back to 5 hours the fourth night. So when you average it out, it might average out to 7 or 8 hours, but it's not actually happening in a regular rhythmic way. And this is there from the onset of the disease. In fact, the equally interesting question is whether it's even there before the diagnosis. And there's some evidence that it is. there is a literature and a lot of interest in at-risk individuals. And as you look at young people who have not yet developed bipolar disorder, but either by virtue of their genetics, by having a first-degree relative, or by virtue of having other features, are at risk for bipolar disorder, and they already have circadian and sleep abnormalities. So this is probably part of the emergence of the disorder.
Great, thanks. So from Mike Doe, how do the effects of lithium and valproic acid compare in human functional imaging? And are these agents quelling abnormal activities or offsetting them via other activities?
Yeah. So I did a sleight of hand as I was presenting this. Of course, lithium and valproic acid are the two sort of, prototypes, and they have been studied heavily. But most of the evidence on intracellular signaling cascades actually comes from lithium. Lithium is stronger than valproic acid from that point of view, to the point where there was actually some interest in lithium in Alzheimer's disease. There were a couple of clinical trials to see if lithium could slow down or arrest the progression of Alzheimer's because of its neuroprotective effects. That hasn't panned out the way you would hope, but the evidence is pretty decent, and not so much in valproic acid. It's valproic acid's molecular effects are similar to lithium, but clinically it doesn't have the same sort of neuroprotective effects in the human literature that lithium does. Are these quelling abnormal activities or offsetting them via other activities? I don't think, since we don't know what the underlying abnormality is in bipolar disorder, it's hard to answer this question. What I think the work would say, Husseini Manji's and other work, Ron Duman's and so on, would say is that they are enhancing, for example, mTOR signaling. But whether that means mTOR signaling was deficient and it's being enhanced now, or this is a side pathway that impacts something else that really matters, I don't believe is known.
Thanks. So next up from Jessica Babb, even though the prevalence is similar in men and women, I'm not sure what the rates are there differences in symptoms across sexes?
So that's a good question. There's one thing that comes up in response to this is the menstrual cycle. There's no doubt that women with bipolar disorder are more affected. Their psychopathology is affected by the phases of the menstrual cycle, and there are well-established clinical patterns where some women will get a lot worse in the premenstrual period, and then they'll actually look a lot better right after menstruation. So there are differences in how people experience these symptoms. I'm trying to think. My memory also is that men are more likely to have psychotic features and more likely to have worse outcomes than women. So even though they all meet diagnostic criteria, men tend to have somewhat more severe presentation. That's certainly the case in schizophrenia, and I believe it's also the case in bipolar disorder.
Thanks. So next question from Hauksu. I have a question about bipolar patients' social functioning. Do they have any specific social interaction problems, or are the problems similar to those induced with sleep deprivation / MDD?
So no, there is definitely a social cognition literature in bipolar disorder, similar to schizophrenia, indicating that bipolar patients, for example, have difficulty with theory of mind tasks, imagining the intentions and the experience of the other person, and therefore modifying your own behavior to have a more effective interaction. And that kind of social interaction, complex social cues, there are difficulties in bipolar disorder. They're not as pronounced as the ones in schizophrenia, but they're more pronounced than the ones in depression. So they tend to be somewhere in between.
So from Kay Sullivan, could you elaborate on the clinical manifestations between bipolar disorder and schizoaffective?
Yeah, so schizoaffective disorder is in fact related to bipolar. And traditionally it's thought of as sort of an intermediate phenotype between bipolar on the one side, that's more episodic and more mood disorder heavy with some psychosis thrown in, and then schizophrenia, which is chronic and psychosis heavy, but it could be some mood thrown in, and schizoaffective is really in the middle. There is a lot of debate about this, and our conceptions of these disorders have sort of morphed over the years. So these are not clear-cut you know, phenotypes where you can put a box around it and you can develop a diagnostic test and so on and so forth. They're really best estimates and consensus agreement diagnoses. So there is not a lot of validity to what schizoaffective disorder should be and what bipolar disorder should be. Generally speaking, people with schizoaffective disorder have more chronic psychotic features. They still tend to have mood episodes. In fact, you can't have the diagnosis unless you have significant period of mood episodes. That can be depression or mania. Some schizoaffective patients will have only depression. Some will have both depression and mania. So schizoaffective disorder is sometimes subtyped into schizoaffective disorder, bipolar subtype, and schizoaffective disorder, depressive subtype. And the bipolar subtype is closer to bipolar disorder. The depressive subtype is closer to schizophrenia. Maybe this is more than you wanted to hear, but so schizoaffective is this nebulous concept that people have tried to impose some order on. On average, schizoaffective patients tend to be more severe, tend to have a more severe illness. So outcomes tend to be worse. They're less likely to finish school, less likely to hold a job, less likely to be married and have children and have good life satisfaction compared to bipolar patients. That's on average. You can definitely find the schizoaffective patient doing better than a bipolar patient, but on average, the chronic psychosis makes them a little more like schizophrenia.
Thanks. So going back to the animal model theme, from Rachel Wilson, what features of bipolar disorder are captured by current animal models, and what features of bipolar disorder are not so well captured?
Yeah, another great question. So in isolation, certainly, you know, depressive features can be captured in a variety of animal models. And again, there are probably people in the audience who could lecture me on this. But things like, you know, the models that pharmaceutical companies use to develop new antidepressants, the forced swim test and the tail suspension test and so on, learned helplessness. So it's possible to social defeat. It's possible to model anhedonia and lack of motivation and maybe to some extent low mood in animals. Mania can also be modeled, like these clock mice that I mentioned that are hyperactive, novelty seeking, and cocaine sensitive. So a lot of manic features can also be modeled. The clock mice do that. Also, interestingly, Tadafumi Kato from Japan has mitochondrial DNA polymerase. Is it a knockout, or I forget now what exactly the genetic modification is. But what it does is these animals accumulate DNA mutations over time, and their mitochondria become less and less effective in their mitochondrial DNA. And therefore their mitochondria become less and less effective over time. Those animals also become hyperactive. So he has argued that that's a model of mania, for example. Substance use is another one that's such a core feature for bipolar. And also, of course, there's massive literature on substance use and capturing various aspects of that in animals. What isn't captured, I would say, is the confluence of all of these things. As far as I'm aware, there is no animal that cycles through a depressive-like period and a manic-like period, and sometimes dabbles in substances and sometimes doesn't. You know, it's sort of the putting together of all of these different features. How is it that, you know, something that looks really like a disease entity, like Ross Baldessarini says, you know, you can sort of, you know who they are, and, you know, there are rules to this, and clinicians can see things evolve in their patients over time and recognize the patterns. And yet it's so variable in its presentation, you know, over time within an individual and between individuals. That's a challenge that really hasn't been captured on the animal model side.
Thank you. So we have a few more questions. It's great how engaged people are. So from La Dionisi, are there any updates in the relationship between bipolar disorder and borderline personality disorder? Could borderline personality disorder be included in the bipolar spectrum?
Yeah, it's controversial, and it's always been, and it still is. There wasn't enough of a movement to include this relationship in the diagnostic system, so the DSM does not recognize any relationship between bipolar disorder and borderline personality. I mean, it's mentioned, but officially sort of in the criteria that it's not recognized. And the idea went something like this. Bipolar disorder is sort of the extremes of this mood instability, you know, that all people have, mood fluctuations, but then when that's taken to an extreme, that's what you get for bipolar disorder. And borderline personality disorder is also characterized by severe mood fluctuation. and anxiety and substance use and some psychosis. So the features are very similar. Maybe borderline personality is sort of a special case of bipolar disorder. You know, some proponents have collected some evidence that suggests that, but I would say at best there's a tenuous relationship there. It's not a clear thing to say, oh yeah, bipolar is borderline is a subtype of bipolar. That's just not there.
So next up from Cassandra Pasadin, which episodes, depressive or manic, are more dangerous for patients in regards to self-harm or suicide?
So suicide is more closely associated with depressive episodes within bipolar disorder, but it's not zero in mania, and it's also not zero in euthymia. That's that period of the absence of episode. So people with bipolar disorder are at elevated risk of suicide over time, but the risk is particularly higher in the depressive episode.
Thank you. And then for another question from Madeline Bailey, do you see patients who come in with just mania? How common is that? Oh, hello, Dost, are you still there?
Oh.
Yes, the internet was unstable.
Sorry.
Sorry, let me just repeat the question. So from Madeline Bailey, do you see patients who come in with just mania? How common is that?
Yeah, so I see that Andy Nirenberg actually put a paper he had written on this already. It's called unipolar mania. Well, I don't know what Andy's paper said, but I believe it says something like 3 to 5%. So it's a small minority of people with bipolar disorder who are said to have unipolar mania. It's occasionally seen. I've seen an occasional patient, but you know, it's not common at all.
So I think we've reached the end of the questions in the chat. There's wonderful lineup there. Do we have any last questions anyone would like to raise their hand and ask? Oh, Mark Anderman?
I just wanted to follow up on the oscillation question that I asked earlier. And you had mentioned the idea that there's a lot of excitement around real-time tracking of different states. And I'm just wondering whether or not that could be coupled to kind of IV or other delivery of drugs in a way that can be more tightly related to the current state, so that you don't over-medicate just because you want to make sure they don't do anything drastic, and then suddenly that plunges you from mania to depression. Like if you're able to just react over the course of minutes or hours, would that actually allow you to get closer to the steady state?
Boy, wouldn't that be great? Yeah, so I think, you know, in principle, that's exactly the kind of thing that probably would be more effective than what we do now. I mean, historically, traditionally, I'll tell you, in bipolar disorder, the best way to prevent episodes is early intervention and early warning. And it's usually families that have played that role. So the typical bipolar patient would have almost an agreement, sometimes actually written agreement after they've suffered enough and they really don't want it anymore, that would say, if you know, dear parents or dear spouse or whatever, if you see the following behaviors, please call my doctor, tell them what to do, and you know, I will do what my doctor says, and sort of make a commitment to that kind of early intervention. Because you know, these nonlinear effects, once at the inflection point, if you catch it early enough, very modest medication changes or sleeping well for a few nights might actually cut things off at the pass. But once the episode's taken a life of its own, you know, the same modest intervention is going to be a drop in the bucket. So it's really, the name of the game is early intervention. So that's where you're going with this. The problem that we have now is that the tools that we have to intervene are very blunt instruments. So the antipsychotics that we use, for example, to suppress manic symptoms, you know, the mood stabilizers, even the benzos to you know, to kind of reduce the anxiety and agitation and so on. They take effect over days and sometimes weeks. And, you know, there's big lag times in how much can get into your system and how long it stays in your system. So what you're describing right now is really, you know, with the tools that we have available, isn't really realistic, but that's absolutely the target. Replacing the family member who over a few weeks says, you're not your usual self, we should call your doctor, and the doctor will give you some extra medicine, and a few weeks later, maybe things will be better. If you could actually do this kind of real-time monitoring, and then also be able to, you know, calculate the sort of half-life of the various symptoms as they're running through and where you are in the build-up towards an episode, so you could calculate what intervention is needed and be able to deliver that.
Mm-hmm. Great, thank you.
Please give us that.
So I wanted to add a final question of my own. Dost, so in your own research, what are you most excited about? So in the next 5 years or so, you know, what do you think is most promising, or what are you most hopeful about?
So yeah, I mentioned a little bit, this is work that we started with Bruce Cohen over the years and have continued on bioenergetics, ATP synthesis and availability, and the balance between oxidative phosphorylation and glycolysis. That's actually, you know, we've collected a lot of evidence that these are abnormal in bipolar disorder. We've actually talked about it, some of these things in previous HBI sessions. We are, and this also ties into all of the well-known connections between bipolar disorder and metabolic conditions and other medical conditions. You know, these are disorders of the body. They're not only disorders of the brain and the mind. And so if we can find ways to intervene and improve energy availability in a activity-dependent way, when the brain really needs it, when, you know, when it needs to become more active, I think that actually would probably make a positive impact. We're working on a bunch of things. One of them is intracellular insulin, intranasal insulin. So it's actually also being tried in Alzheimer's disease, but apparently it's not going as well there. But you know, intranasal administration makes insulin available to the brain because it crosses the cribriform plate and gets taken up into the olfactory bulbs, and from there to the frontal cortex without dropping your blood sugars. So it has no systemic effects, and yet it's a CNS insulin administration. And you know, that's one of the examples of things we're working on that might improve brain bioenergetics in a way that that helps bipolar patients.
That's really interesting. Thank you. Thank you for that really fabulous talk, and just the range of questions that you've answered and so quickly. Like it's incredible for an hour and a half. And we're really grateful. And for the audience, I think that this is a cool thing we're trying with the you know, Disorder 101 type program. And if people have suggestions for other disorders that they'd like to see or other topics, we would be happy to take those. Josh, I don't know if you want to say any final words.
I'll just add my thanks. It was a great talk. I love the way you answer questions, and you know, informative but succinct, and it was just a wonderful session. I am so glad I got to hear it.
Thanks, everybody.
Yeah, thank you very, very much. It was wonderful.
Bye now.
Bye-bye.